Okay, so I'll send to you live.
Cool.
And I think from now it's recorded.
Okay.
It's 7.
Fab.
And people will trickle in.
Cool.
So go for it. Shows you this.
Okay. So, hi everyone. I'm Zina. I'm currently an F1 at UCLH in the Infectious Diseases department, which is why I was asked to give this talk. So, what I will try and cover is some high yield topics, give you some tips and tricks for exams, and answer any questions that you have. So, of course, feel free to either speak out or just type whatever you have to say in the chat. And if there's anything that comes up and I can't answer it, I promise I will ask a senior colleague and I can give you guys an email, drop you the information some other way. Cool. So we'll get cracking. So I'll tell you a little bit about what we'll go over. We'll go over TB, malaria. We'll just do a quick summary of pyrexia of unknown origin or fever of unknown origin. And then I have a mnemonic, or not a mnemonic, but a memory aid to tell you about the hepatitis, even though it's technically a gastro topic. I just think it's a good thing to have in your back pocket. We'll do a quick summary of COVID because it still exists and is very examinable. And then I'll put in the summary, just some tips and tricks. And I've only got one reference, but I think it'll be helpful to you. And I've got some feedback requests. So there'll be a QR code twice in the talk. And if you guys could just let me know if there's anything you liked, didn't like, or how we could modify this for the future. Cool. So we'll get started. So before we get going, I'll tell you that I always find it really easy to remember things if there is like a celebrity association or a film association that I remember. So I don't know if you guys have seen Moulin Rouge, but the character that Nicole Kidman plays, Satine, is always coughing up blood and she ends up having TB, and this is a spoiler, but tragically passes away from her TB. So in the stem of the question, so this is also something I think is important. We'll obviously go through the theory, but I think there's so many places you can find really good coverage of pathology and treatments. I just want to make it as memorable as possible for you. So often in the stem of an MCQ, it's going to say this person is of South Asian descent, and then it builds up to this picture. So they have a cough, they're having there's hemoptysis or maybe not hemoptysis, they just don't feel themselves, they've been having night sweats, they're losing weight. And this is actually a good thing to ask in histories generally. Always ask your B symptoms. Have you lost weight? Are you having any fevers? Do you notice that you're waking up and your sheets are drenched? So just to kind of summarize the pathophysiology. So it's an organism. There's lots of different types of TB, first of all, but primarily, I think in exam scenarios for medical school finals, it will be pulmonary TB. But you can get things like genitourinary TB, and they have like a sterile pyuria. You can get a spinal TB, which is called POTS syndrome, and you have sort of your collapses of your vertebrae. But pulmonary TB is obviously like the number one for finals. So as I've said there in the slides, there's a primary, so the organism, it multiplies at your pleural surface. You get these GON focuses, and then when you get these build-up of macrophages, they take TB to your lymph nodes, and you get a GON complex. I wonder if I'm pronouncing that right. But if you see that word, sometimes when they try and put in a bit of pathophysiology in the question. So if you see the word GON, it's probably a mycobacterium like TB. So in terms of investigations, you need them to give you 3 acid-fast bacilli positive sputum cultures. So that's what the patient needs to provide. Just for interest, if you ever need to have a patient produce a sputum and they haven't got a productive cough, you can give them hypertonic saline, and that will help people produce a productive cough. But really, it's such a hallmark for pulmonary TB. They should be coughing and they should be producing some sputum. Okay, so you can also culture the sputum, but it takes time to cook. So sometimes it can take about 3+ weeks for it to cook. And then there's the NAAT tests, but they are not as sort of conclusive as your acid fast bacilli cultures. And then finally, on your chest x-ray, so when you've asked for lots of different investigations, you say, I also want a chest x-ray as my imaging, and you get that buzzword, which is the bilateral hilar lymphadenopathy. So if you see that mentioned and you've got that clinical picture, then it's most likely TB. There is a helpful table that tells you about the MAN2 test and screening for latent TB that you can find on lots of popular question banks. But something that's often important to remember is that it can give you a false positive in patients with HIV, and sometimes that's where they're guiding you with the stem. So also, if a patient comes in and you find that they're positive for TB, you must do a HIV test. Cool. So the management of the active disease, I think the important thing here is that you keep a little mnemonic in your mind. So people often use RIPE, but before you even get going with the treatment, you have to check their renal and liver function, because sometimes you have to reduce the dose of rifampicin if their renal function isn't great, and they tend to kind of manage ethambutol in a different way as well if the renal function isn't great. Because of the effect of ethambutol on your vision, they ask people to have the Ishihara plate. So as you know, or maybe don't know, the Ishihara plate is just for your colour vision. So they'll ask you to test those before you start somebody on ethambutol. Because it can also cause optic neuritis, and we'll get onto that shortly. So you give someone 2 months of the RIPE and then 4 months of just the rye. So rifampicin, key side effects to remember: it can change the colour of the urine, give you interstitial nephritis, cause hepatitis, which I think a few of these can, and is an enzyme inducer. So it can impact other medication that patient is taking, so you'd want to counsel them on that. Isoniazid, so I remember this because Zid sounds a bit like ZAP, and thinking about things like peripheral neuropathy is often the main side effect in finals land. And then pyrazinamide is the other part of the treatment, and this is a bit of a, I want you to kind of really come with me on this journey, but I think of it as like a pyramid, because it's got the word pyra at the beginning, and pyramid, crystals, gout. So you get this hyperuricemia that can cause gout. And then finally, ethambutol or ithambutol for a memory aid. It can cause optic neuritis, and that's why it's so important for you to do the Ishihara plates before you start somebody on treatment. There is, if it again comes up as an OSCE station, it's really important to explain to patients about the importance of sticking with it, because it is a really long treatment course. Like, you're asking someone to stay on active treatment and take several tablets a day for 6 months. But you can involve TB nurses who are excellent, and they can counsel the patient, they'll monitor them. And then also things like if somebody has pulmonary TB and they live at home and have other family members, it's important that you screen the family members for any signs of TB. So this is my first feedback QR code that you will slowly get sick of. But yeah, anything you want us to do differently or anything that you would find more helpful, just let us know and we can make the amendments. So this is a question, and this isn't, I haven't written this question, so it's not mine, but I'll give you guys a chance to read it, and then I will do the poll and just let you choose whichever one you want. We'll just give it like 30 seconds and see what people say. I don't know if you guys can see it. One sec. Sorry. Oh, yeah. Cool. Okay, we won't get stuck on it for ages and ages because, you know, I know this is your evening as well. I don't want to take up too much of your time. So the answer, when you guys get the slides, I have got the answers in the comments and like explanations and things like that. So I just didn't want to take up too much slide space on the lecture. But the answer to this question essentially relies on you picking up that or recognizing interstitial nephritis. So it kind of is a bit of a renal question as well. I think that there are a few red herrings. So her work as a vet is a red herring. The polycystic kidney disease is a bit of a red herring, and then the combined oral contraceptive pill. So when you see that answer, the answer is 1 or A, and the fever and a rash is really classic for interstitial nephritis, and rifampicin can cause it. Like, they often would have called it like quite a dirty drug. It's got lots of side effects, but obviously it's so integral in the treatment of some really important conditions that it's still used. Animal exposure isn't really related to interstitial nephritis. As you know, like sort of polycystic kidney disease, I think would you expect to see a manifestation of it in like a 25-year-old, which says her mother was diagnosed at 45. So you have to kind of think, like, is this like the recessive type of polycystic kidney disease, and try and build the picture in your head. There's no associated use with the combined oral contraceptive pill for anything like interstitial nephritis. And then renal TB is rare. So do you know when they always say common things are common? So just try and think, like, am I, as a final year medical student, going to be tested on renal TB? Probably not. So that is our TB section done. If anyone has any questions, please let me know. Next one is malaria. So I don't know if you guys know that Cheryl Cole, I don't know if she still goes by Cheryl Cole, got malaria and was really, really unwell. And again, like I said, celebrity association really helps me to remember. So malaria. It's spread by the mosquito that we know, that Anopheles mosquito. And there's a few different types. So there's like Ovale and Vivax, but they're very rarely tested in finals. So falciparum is the most common in real life and the most severe and the most likely that you'll be tested on. So as we said, it's spread by a mosquito, and the mosquito injects its Plasmodium sporocytes, which go to the liver, migrate in your hepatocytes, and they are released from the liver, infect your blood cells. And in the liver, they become something called merocytes, and you get hepatosplenomegaly because they multiply. You get splenomegaly because of red blood cell sequestration. So you also see these things like hemolysis, cytokine release, and that's what makes people feel really, really unwell. You then can see the patient come in and they're like, oh, I had a bit of a flu before. And that word, paroxysms, is when people get a fever that like ebbs and comes and goes. So they'll have a bit of a fever and then it will go and they'll have another fever again. It's usually sort of on alternate days, and then they find that they're shivering, and then they're really hot, and then they sweat as their temperature falls. So really unpleasant symptoms. That prodrome is just like usual malaise, feeling like you've got a headache, muscle aches. Importantly, when you take a blood test for this patient, they'll have anemia and they'll have jaundice, but you won't see any rash on them. You won't see any, they won't have any palpable lymph nodes anywhere. So sometimes it's good to kind of be able to characterize the presentation from what they've given you in the stem. And then, as you know, in terms of your investigations, they always say, please say why you're asking for whatever investigation that you're asking for. So the blood film and the parasite level is key, because you need to see how infected a person is, essentially. On your FBC, you'd expect to see like an anemia, a thrombocytopenia, and then on your user needs, you might see a renal failure. An ABG is a really useful thing to do because it can tell if there's any lactic acidosis, which tells you how unwell a patient is. So it's really important to try and do one. And unrelated, but if you get a chance in final year or even F1, try to learn how to do an ABG with local anesthetic. It makes all the difference to you actually succeeding with the procedure and the patient complying and being comfortable as well. So in terms of the management, it's Reamet for your falciparum, and everything else you're giving chloroquine and then primaquine. But again, I think it would be unusual to be tested on the management of malaria apart from this real barn door stuff. So let's go on and ask you guys the question. So 35-year-old woman presents with a 3-day history of cyclical fever, myalgia, and fatigue. 1 week after returning from Kenya, where she was visiting relatives. On examination, she had mild jaundice and splenomegaly of 4 centimeters. So hopefully this one should be a bit more straightforward, and I will get you guys just to tell me what you think the answer is in the poll. Yeah, this one is when they give you a gift of an easy question. This one is that. Cool. So with this one, the answer is obviously malaria. The important thing I think to pick out in the stem is that it says here she's returning from Kenya where she was visiting relatives. So that's sometimes, apart from the symptoms, so the cyclical fever, that prodrome that we talked about, and the mild jaundice, there's a group of patients they often talk about on the ID ward, or they say people who've gone to visit friends and family, they think they're immune because they've grown up in the region, and they now think, well, I've always been around the high risk areas, that this should be fine for me, so they don't take any prophylaxis. So sometimes that can also help you with the question, especially if it's not as obvious as this. All the others are red herrings, and I think what's important, I think maybe I certainly didn't know this as a final year and have a very vague understanding of it now, is just what you are likely to contract in certain parts of the world. So Japanese encephalitis, we're not in the right part of the world. In hepatitis A, there's nothing in the stem to indicate there's any sort of hepatitis A. They've not eaten anything that would make you think of hepatitis A. They've not engaged in any activity that would make you think they might contract hepatitis A. In yellow fever, you see things like lots of bleeding, and it's just not the right part of the world for typhoid. So we'll move on. Cool. So I was asked to talk about pyrexia of unknown origin, and what I'll say about that is it is more likely to be a history-taking station in an OSCE than necessarily a final year you trying to delineate a diagnosis, because it's very difficult to diagnose because it's quite a bit of a mysterious diagnosis. So the definition of pyrexia of unknown origin, PUO. So they've got a fever of 38.3 for beyond 3 weeks. I've highlighted the threes just to help you guys remember. And they've had a week of inpatient investigations that have not kind of provided any sort of alternate cause of their fever. There's 3 different types that we usually think about. So there's HIV associated, obviously patients with HIV, neutropenic, so people with neutrophil of less than 1 by 10 to the 9, and then nosocomial is when they're inpatient, so something that's developed while they've been in hospital. Again, the key is obviously the history, and the something I'll say just quickly about taking a history in an OSCE is that it's really important not to get stuck in the presenting complaint part that eats up a lot of the time because you're trying to work out what's wrong. But then you miss all the marks for like past medical history, do you smoke, any allergies, social history, all of those bits and pieces. So just try and remember when you do practice your histories to like move on, even if you're none the wiser about what the diagnosis is in that section. So you adapt your Socrates like you can with so many of these histories. So you want to ask them, when did it start? Was it acute, gradual? Do you feel that the fever's there all the time? So what's the character, or is it intermittent? What's the timing? Is it sort of night, day? Is it there all the time? Anything make it better, like paracetamol? Anything make it worse? Are you finding any associated symptoms? So are you waking up at night sweating? Your sheets wet? Have you lost weight? Are you tired? So just those B symptoms that we talked about. And then I think what can work well is just to do, again, if you've got a bit of time to play with, like a systems approach. And I always think a good way to start the systems approach is to say to the patient, listen, I'm going to want us to go from head to toe to make sure I don't miss anything, and it will help keep me right. Please feel free to interject if you feel like I've missed something, because then it also shows the examiner that you're thinking systematically. So that's your systems-based approach. And when you're talking about past medical history, so you want to ask if they're immunosuppressed. So that can be anything from, are they somebody with HIV or cancer, or are they just somebody who receives like a Crohn's disease, like a monoclonal antibody for their Crohn's disease? In terms of the social history, we always ask, do you inject drugs? But have you ever used drugs and injected them? Have you ever shared needles? Any other sort of like risky behavior? Sometimes it's also good to just find out if there's anybody else at home that's unwell as part of your family history. So is this something that they could have, is this an infectious disease that everybody could have? And then we say there about sort of unusual jobs or hobbies. Sometimes you see in the STEM, they're like, I work in the sewage, or I'm a coal miner, and then it helps you understand the diagnoses. But just asking people, is there anything that you do that's a bit different? Is there anything in particular that you pass the time with that's unusual? And then also asking them, which is key in any infectious history, is their sexual history and the travel history. And those can be a bit awkward to bring up. And I think sometimes it's just good to preface it and say, I'm really sorry, I just have to ask you a couple of personal questions just to understand a little bit better about what's going on with you. So that is pyrexia of unknown origin. I couldn't, to be honest, I was thinking about potential MCQs, but I think it's quite difficult to test it in an MCQ format because there's not any definitive answer. So we'll move on and just do a little bit about tropical infections. I think this is a really nice way to think of them. And again, this isn't something, I think malaria seems like the most testable one to me. And in my experience of like finals and, working through question banks, I didn't see a lot of these come up, but it's not to say they can't come up. And while it might be quite low yield, I think it's interesting, especially if you're interested in anything like that. So just to kind of picture what is what. So like malaria is a protozoa, but then when we think about things like tapeworms and roundworms, they're more like helminths. So I thought I would first of all chat to you about the different kinds of conditions that we can see. And there are two. So if I just show you this back. So the trypanosoma, if I'm pronouncing it correctly, there are a couple that I think are worth knowing about. So again, like I said, I like to have a celebrity association. So there is an American type and an African type. So the American type, the bug is called T. cruzi, so like Tom Cruise, who is an American, and it causes Chagas disease, which also starts with C. So as I said, it's spread by bugs, and you get the patient that has this eyelid swelling that you see classically, and they call that Romana sign. I think some people quite I like to remember the eponymous name signs just because it helps me remember, but I know there's really a move to come away from that, and we'll touch on that in a little bit. So yeah, they'll have some fevers, you'll be able to feel some palpable lymph nodes, hepatosplenomegaly, and cardiac disease as well is one of the manifestations that you can have with Chagas. And I think the thing here is in the STEM will say, a patient traveled to somewhere in Central America, or just to kind of help you contextualize what might be going on. And then the African trypanosoma or trypanoma, I don't know why I'm mispronouncing that, is called sleeping sickness. And there are two types. So there's the Gambianese variation, which is the most common, and then the Rhodesian variation. So I think Rhodesia was maybe previously Zimbabwe, so colonial name, but I've highlighted it. So it's East Africa and it's rarer. So R rare to help you remember. It's less likely to come up. It's spread by a fly instead of a bug. And the presentation is you get the tender nodule at the site that you've sort of been stung, and you can get a hemolytic presentation. So you get a rash, like I've said, fever, rigors, swollen lymph nodes. So the cervical lymph nodes swell up, and that's called Winterbottom sign, which is very depressing and horrible history. So Winterbottom sign is this sort of posterior cervical lymph node swelling, and Winterbottom was a physician, and I think he was actually an abolitionist, but he reported this sign in slaves because slave traders would feel for slaves' necks to see if they could feel the cervical lymph nodes, and they wouldn't buy them if they could feel them because they knew that this person was unwell and then could develop this meningoencephalitic manifestation where you're getting convulsions and it can develop into a coma. So again, yeah, it's lots of horrible parts of history are immortalized in medicine, but I think sometimes with these, I think he was an abolitionist actually, so we're not sort of commemorating a horrible person. And then I also, if I show you again, we'll just go back a couple so I can show you where leishmaniasis, so it's also a protozoa. And I'll talk to you about leishmaniasis very briefly. So leishmaniasis, it is spread by sandflies. It is in South America, Central America, Asia, and Africa. So knowing the region isn't as helpful on this occasion because it's so widely spread. But you get this cutaneous manifestations. There's kind of three types that you see, and I've said sorry, I'm pointing at my screen, which is not helpful to you, but there are a couple of different agents that cause this. So you get skin ulcer, and I think you can see that there where you get a bite and then it will develop into a scar. There's mucocutaneous, and that is in the mouth and the nose where you'd get the ulcer. And then you have the visceral one. So you get these dry, warty skin lesions on the hands, prolonged fevers, and massive splenomegaly. It's worth just Googling images of a few of these things just so you can see it and kind of have an idea. I don't know what I think maybe for the licensing exams, most exams will be done online, so they can include images, and it's helpful to maybe be able to recognize a couple of these bits and pieces. So I am going to ask you the third question here. So start popping. So which of the following is the most common pathogen, is the most common cause of African sleeping sickness? So I'll let you guys have a think about it. Cool. Give you a bit longer. Oh God, sorry. Fab, brilliant. So we'll wrap it up there. So the answer is actually E, and I'll just go through those with you for a second. Sorry, give me a second. If you just bear with me 1 second, I'd actually had these notes all on my phone, but I think I missed this one really importantly. So just give me one moment. I want to just talk through the answers in depth. Yeah, so A is leishmaniasis, so we are thinking about ruling that one out because it's not the cause of African sleeping sickness. B, the Trypanosoma cruzi, so like we said, Tom Cruise, that's the American one, so no good to us. C, so the Brucei rhodesiense, like as we said, rare in Rhodesia, so it's not that one. Ascaris is actually a parasitic worm, so it wouldn't be that one, so the answer is E, the most common one, the East African one, and that's the answer. So like I said, I just wanted to touch on hepatitis B because hepatitis B serology comes up all the time in finals questions, and it's really, really hard to figure out. And this is not my memory aid. A good friend of mine made this up, and it has always served me really, really well. And ever since I memorized it, I've been able to answer the questions correctly. So I just wanted you guys to have a look at that so you could see it and see if it would be of any benefit to you. I know there's a swear word there, which I'm not sure is allowed, but it just is a way to kind of try and get in your mind what the serology actually means. And in practice, we do have to interpret the hepatitis B serology. So I think it's worth having a tool to keep it in your mind. And I'm just going to leave it on the screen for a little bit, but then I'm going to ask you guys a question about it. So I don't know if you want to like screenshot it or what we want to do, but I'm going to move on to the question and then I can flip back to let you have a look at the serology to help you answer it. So I'm going to skip to the question. and I'm going to start the poll. Oh, sorry. And then we will go back and I'll show you the serology. I'll let you guys just have a look at the question and see what you think, and then we'll go and have a look at what we saw before. So let me flip back briefly to show you my little memory aid, and then we'll come back to the question. So we'll have another look at the memory aid. Cool. And then we'll have a look back at the question, see what you think. Great. I'll put everybody out of their misery. And this is actually the question we have the most sort of answer distribution. The answer is actually D. And I don't think this one needs an explanation as much because it's sort of, it either is, it's much more black and white, sort of it is or it isn't. I'd really encourage you to use my friend's memory aid. It's really helpful and it served me really well since third year where I learnt it. So I will credit her, Rachel McVeigh, and make sure that she gets the credit if you guys find this useful. So last bit I want to talk to you about is COVID. So COVID is very much still around. Obviously very grateful that it's much less fatal and less severe now because of vaccines, but it's very much something that could come up, especially in an OSCE station. They say, you know, you've taken a history from the patient, they show you an x-ray, and I think the next thing is that what would you do next, you know? So first interpret the x-ray. I don't want to teach you how to suck eggs. I think you all have gone through x-ray interpretation many, many times. So just doing your usual Dr. ABCDE. And I think what I was once taught was if you're looking at the chest x-ray in an OSCE situation and you can't ascertain what's wrong with the patient and they're just sort of generally unwell, it's probably COVID. And this is quite like a classical COVID x-ray, COVID pneumonitis. I've shared the link from where I pulled this from. It's a website called Radiology Masterclass that it's free to sign up to, really good for revision of radiology stuff because it's one, you know, where you hover your mouse over it and it will tell you like what thing you should have picked up on the image, and they have it for everything. So like trauma stuff, hands, legs, everything. So really, really worth looking and practicing. And that's one of those things that you can practice on your own. If you don't have anyone to practice with that day for your OSCE prep, it's a good one to think about. So they say, you know, what would you do next with this patient? You think they've got COVID. So you've obviously tested them. So you send away we call it Copan or whatever swab you want to send away. So viral swab comes up positive. You then want to isolate them. So really important, they're in a side room. And then when you think about your investigations, just from when you're presenting, this is just from OSCE Stop where they talk about having a system. So they think they use boxes. So things like bedside investigations. So essentially like a set of OBS. O is for orifices. So like, do you want to send a urine sample? Do you want to do a PR? What do you want to do? X is for imaging. So your x-ray that you would do. So I want to give this person a chest x-ray. And then S is for any special tests. E, sorry, is for things like ECG. And then the S is for special tests. So I think it's good to always keep your diagnostic kind of window wide. So even though we think, oh, this might be bombed or COVID or whatever, a pneumonia, like if they're tachycardic on the OBS, you still want to do an ECG just in case. And then, as we said, when you are requesting something like a set of bloods, you just want to say why you're requesting it. So why am I requesting a full blood count? Oh, I want to see a white cell count. Oh, I want to see a CRP, you know, and then I also want to do an ABG. I want to see if they are acidotic. I want to see what the story is. Imaging wise, what sort of imaging? So you've done a chest x-ray, you might want to do a CTPA as well, if you're particularly concerned. And then we talk about management now. It's things like oxygen, you're giving people steroids like dexamethasone if you think they need it. There's also the antivirals, so things like Paxlovid and remdesivir. But I think what would be good to say at this point is, well, this is very much local policy specific. So whatever my local department is, or whatever the local guidance is, I'd follow that. I think it varies, not just trust to trust, but hospital to hospital. And then always it's an opportunity to do some public health engagement with patients and say, oh, look, if you haven't had your vaccine, this is a really good time, maybe in a couple of months, to consider getting vaccinated, and, talk to them about the importance of vaccination, counselling them. And so, in summary, just even if you don't know what's going on in the OSCE station, so like a fever of unknown origin, which I think would be a really nasty OSCE station to give people, just try to approach it systematically and go through, whether it be your imaging interpretation, your history taking, as systematically as you can. With lots of patients that have an infectious disease, you should always do an HIV test. So whatever it might be, TB, leash, if they've just got a presentation where you think this is quite unusual for this person to have become so unwell, do a HIV test. It's really important. So I said there about memory aids like RIPE or that hepatitis B one, just to help you remember stuff. And I think what I'd say is lots of your other modules are going to include some section on infection. So in your obs and gynae, there's going to be stuff on sexual health, pneumonias, in RESP, in GI or your hepatitises. Like, it's going to come up time and time again. And what's important in finals is that you're able to recognize the patterns from the STEM. You're able to recognize, like, they've chosen this demographic of people that is very likely to have XYZ. And it's not always, it's not brilliant because you're stereotyping people, but for the sake of finals, it's really important to kind of try and keep that in mind because it will help you. And I think this is, I said the one reference I'd really, really recommend is Radiology Masterclass. It's free and just really excellent for practicing all your radiology, especially if you're not confident presenting them, which I never really was, and it was just a good thing to go through. So this is the QR code again for any feedback that you have. The next talk is going to be on the 23rd, which I think is Thursday, and they're going to be talking about upper GI. There is a email address if you guys want to raise any questions or you have any comments. And yeah, I'm happy to hang around because that's the end of my slides and answer any questions that you have. I know this is just a short and sweet 40 minutes, so any questions you have, you want to type in the chat or anything you want to email me with. I think I've put my email. I will put my email in the chat. And even if you're just like, I'm only an F1, but if you're interested in infectious diseases or you want to know what it's like as a job, please feel free to drop me an email. But yeah, I'll hang about for about 5-10 minutes, and anything you want to ask, feel free. Sorry, I've just seen one of the questions. Do I mind explaining the memory aid and the answer following the Hep B question? Yeah, of course. Let's pull back. Sorry, hepatitis. What was the answer for hepatitis question 4? Let me show you that. Let's go back. Hepatitis question 4. So the answer is D, right? So let's look at that together. Sorry, when you see me look down, I just have all of my notes written on my phone, which is why I'm looking down. I'm not just sort of checking my phone when we are doing our talk. So with the Hep B question, so this person is the S antigen negative. So they haven't caught the disease, right? So they're not actively currently now either an acute or chronic have the disease in the sense that like they're actively Hep B positive. And then they're HBsAb positive. So HBsAb, so that's the antibody. right? So they're positive for IgG, so going further back, and negative for IgM, which is in this moment more recent. So we know that there is potentially an element of past infection here, right? And then they're HBC antibody positive. So anti-HBC antibody positive. So that means that they've caught the disease. So they actually have the infection. They're not vaccinated against it from the memory aid, if that makes sense. And then HBE antigen is undetectable. E is when they are ill, so acutely infectious. So when we put that picture together, the answer is D, because they've had this past infection. So going further back, they've not been... they have actually caught the disease. It's not from vaccination, and I think that's why that answer is D. So they've cleared the virus because it's not their HBS antigen negative. Does that make sense? Sorry, I think maybe I've not talked through that in the most logical way, but I can go through it again if that's helpful. If I can think of any other, like I used a lot of memory aids to help me with my revision, and I just found that when you sort of tailor them, it's really much easier to remember. But yeah, I'm happy to. Obviously, they're not all ID ones, and I think the thing about ID for finals is going to differ from place to place, but it's not like, I think apart from the big hitters, it's often not a huge amount of the questions. People tend to have like malaria or something easier to distinguish straight away. So somebody's asked here, what would a patient's Hep B serology look like if they'd been vaccinated? So the vaccination, they'd be anti-HBs positive. So again, auntie sorted me out, so I've had the vaccine. And that usually, when you put that, when they show you that, it's much more easy to identify. So it often doesn't come up as someone that's had past infection. It's usually that they've actually been vaccinated. So that's the one to look out for, the anti-HBs. Someone also asked about helpful tips and memory aids for antibiotic coverage. This one is a real corker, and I think it's actually, I haven't got them. I don't have any helpful memory aids, if I'm honest for that. Before I did my medical degree, I studied to be a pharmacist. I worked as a pharmacist for 3 years. So I always some of that is just from my previous pharmacy knowledge. It's in the brain. So that's not a very helpful answer. I'm really sorry. I don't really have any good memory aids. I think definitely what I would say, though, is if in an OSCE scenario is someone and they say, what would you treat this patient with? I would always say I would refer to the local guidelines and I would check their allergy status. So almost got burned by this in my final station. So it was neutropenic sepsis and the patient had a penicillin allergy. And on the last second did I ask, otherwise I'd have given them a penicillin and they would have been fatal. So just say, I just want to check the allergy status, and I'd refer to microguide or something like that. How do you differentiate between typhoid and yellow fever? I'm really sorry. I don't think I'd be able to answer that off the bat without looking into it. I think with yellow fever, they always have like bleeding from in the stem, they'd have bleeding from like an eye or something quite dramatic like that. But I would definitely look into that and just make sure that you know the difference. But feels quite low stakes for a finals question, but I'm happy to look at it for you and also just drop you an email if you'd like me to. That's no problem. Any other bits that anybody wants to know about, or anything that you feel like infection wise that has come up for you and wasn't clear, or you would want us to chat about a bit more on future things? I'm happy to put something together, even like a brief PDF just with a few bits of information about other infections that you guys want covered. Cool. I think we're probably coming to the end. The one thing I would say also is obviously best of luck for everyone who has finals pending. And the other thing I'd say is make sure you have a break over Christmas. Don't just do loads of revision. Like, you need to have time off and relax and stuff and spend time with friends and family. But yeah, I think that's us, isn't it? So thank you, everyone. Thank you for your attention and engaging with the poll. I really appreciate it. Yeah, sorry, I was going to say I'll turn off my camera, but I'll still be in the background for a little bit longer if you guys have anything you want to ask. Cool, everyone. I'm gonna step out now, but I have put my email in the chat. Genuinely, anything that comes up, please feel free to drop me an email. Anything that you need, yeah, you can drop me an email. Thank you all so much for your attention. Bye.